So do you have any trials about lymphoblastic leukemia?
Yeah, but less cases in general because I'm not pediatrician, so we have more the CAR T for pediatrician. I don't have a big experience in CAR T with acute leukemia in adults, and I know we are almost to have a product approved in Brazil, but we don't have this experience. I would like to hear a little bit about your experience in adults, because in adults, in the information that we have, at least in the products approved in US, Europe, and also in Brazil in the next few weeks, we are not convinced that can be the end of the therapy, or maybe we have to add the transplantation after.
Yeah.
So if you ask most part of the hematology, we will do a transplantation of CAR T for adults, and we don't like to do that.
It's a very important information. I had heard from the ASCO next week, because they had some data showed that when the patient had received the CD19 CAR T cell therapy, the AML patients, both the adults and AYA patients, even the children, they didn't need to bring to transplantation.
Yeah.
So it's amazing result. And so I know you focus on the transplantation therapy in your center. So when I have a question, when the patient had returned MRD returned to positive or the relapse after transplantation, first, what's your opinion to give the patients treatment like this situation?
In acute lymphoblastic leukemia?
Yeah, include lymphoblastic.
Well, this is a good question now. If you have, for example, not only MRD, maybe we can bring it indirect to a CAR T cell therapy, for example. If he has received before, for example, blinatumomab or other
as we know, we had many drugs.
Yes, we have. So if you
what's your choice? Because I see the presentation yesterday. The BITE had showed very impassioned data on this kind of patient. So we all know the CAR T cell had a very good data. Also had a BITE had a good evidence response. So what's your
very good question
advice?
Because in our scenario,
it's not a clinical trial. It's a real world.
Current real world scenario. Most of the patients that we are having the discussion of CAR T, we have used it before. Blinatumomab, inotuzumab, and transplantation. So we don't have many new options to give. So CAR T arrives in this scenario, and in general, there's easy to understand. But if we didn't use before, Blina, maybe we can use it now.
But from the Zuma 23 trial, they think the PI think that the CAR T cell therapy should be to give the first line.
Yes.
So what's your choice?
Yeah. So what I think is that, and what we are seeing now in the acute lymphoblastic leukemia, the best treatment is always the first treatment.
Yeah.
So we don't have, even in CAR T scenario, wonderful results in the acute lymphoblastic leukemia, relapsed refractory disease, even if we have some case of cure, but they're not brilliant results. So we have to bring this therapy earlier. So we have lots of trials in this conference, bringing Blina and Ino in the first line to curing more patients. But there are other trials and other ideas that bringing CAR T can make it higher. So if we don't have a problem with access, I think CAR T could be like a wonderful consolidation in first line, and we will cure much more patients. 9%, I don't know how many, but we could cure lots of adult patients in first line. I would love to see this. Because I believe in first line. I still believe in the best shots is the first shot.
I totally agree with you. And when the patient had a relapse, even after transplantation and after CAR T therapy, what's your advice for these kind of patients?
Yeah, these are very individual-based decisions, and what we have used it or not before. And if it's a young patient that we still want to cure, I'm not convinced in the very difficult case only CAR T can cure, but sometimes you do the CAR T, the patient in MRD negative, So do I do the transplant or not?
Yeah,
so
the
it's
second transplantation.
A second transplant is very difficult to decide about it because the risks. But if I would say one thing to help the decision, because I don't know the answer, but maybe you could monitor the B-cell aplasia. If the patient is losing the B-cell aplasia.
How long you think is a high risk for the relapse?
The first 3 months, 6 months.
First 3 months?
We have to have the B-cell aplasia for the first months. 3-6 months, we have to have it. So if we lose it fast, I would go fast to the
transplantation.
But in pediatricians, we can have a little bit more time to decide. But in adults, I would not lose so much time to decide, even of the risk that in now. But I hope in the future we know this answer, to transplant or not to transplant.
Yeah.
Because till now, a second transplant is not always a good option too.
Yeah.
So I would love to have an option without the second transplant.